When Erin Mordecai talked about modeling, she said we have to be careful about how we do this. So we're going to have Nathan Lowe now come up, and I guess Erin and the audience are going to get a chance to evaluate how careful he was in his modeling. Nathan is an MD PhD student, and he's going to talk to us on strengthening the global strategy for schistosomiasis and soil-transmitted helminthiasis, a modeling analysis.
Great. It's a pleasure to be here today. So final stretch, guys. So I'm Nathan Lowe, and today I'm going to be speaking about strengthening the global strategy for schistosomiasis and the soil-transmitted helminths. Now, the topics of today are going to be about diseases caused by parasitic worms, otherwise known as helminths, and particularly two groups of these diseases, schistosomiasis and soil-transmitted helminths. And these are diseases that affect over 1.5 billion people across the developing world, so an astonishingly high prevalence. And this is despite efficacious medicines, praziquantel for schistosomiasis and albendazole for soil-transmitted helminths. Now, the presentation of these diseases has a wide spectrum, anything from relatively asymptomatic to more mild anemia and abdominal pain to very severe bowel obstruction, cancer, and even death. Now, the public health strategy that we've scaled up globally is known as mass drug administration. And this is one of the largest public health programs in the world. And this is large-scale, empiric treatment to entire populations. And what this looks like practically is a healthcare worker or school teacher will set up shop and provide medicines to entire populations. And this is because the medicine has a very safe profile, it's often donated or inexpensive, and the disease and infection prevalence is often so high that it's cost-saving to treat entire populations rather than the test and treat that we're used to. Now, the way mass drug administration is done globally is entirely based on guidelines set by the World Health Organization. And so these WHO guidelines really set the paradigm for mass drug administration. And they tell us two major things. The first is that they recommend focusing primarily on school-aged children. And the second is that based on the prevalence, whether above 10% or above 50%, that then dictates the frequency of treatment. Now, the question that I set out to answer is, are current treatment guidelines adequate to address the public health burden of helminths? Now, these guidelines have had multiple iterations, but they've remained relatively unchanged since the World Health Assembly resolution in 2001. In particular, I wanted to ask, who should we treat? What is the optimal strategy here? So why is it that we focus on school-aged children alone? Certainly, there's a lot of good reasons. It's a population we deeply care about. Infection is especially prevalent in this group, and schools provide a central distribution center to provide medicine. But at the same time, when infection is present in younger children and adults as well, if you don't treat those other populations, they act as a reservoir that just drives reinfection, as well as having disease themselves. So this is the first question we wanted to look at. So particularly, is expanding treatment from only these school-aged children to entire communities necessary to bring down disease burden, to even think about elimination? And second, the financial argument. Is this expanded public health strategy cost-effective? Now, the way we approach this is in a two-part model. The first is through a transmission model of these different helminths, so 2 species of schistosoma and the 3 soil-transmitted helminths. And Erin Mordecai was lovely in kind of introducing these models and using basic mathematical principles to show how disease spreads over time and how different interventions can be applied to simulate how that changes those dynamics. We then use a cost-effectiveness model to say, how much bang do we get for our buck, to really conceptualize the comparative advantages of these strategies. And we look at these main strategies. We look at no treatment, which is common in many places. We look at school-based treatment, which is the current recommendation. Then we look at a variety of other strategies, expanding to a broader set of children, and then finally community-wide treatment. And we typically look over a 5 to 15-year time horizon. Now, to kind of give a description of this transmission model, we basically take a population and parse it out into relevant age groups or demographic groups. In this case, we choose these age groups based on targeting. We then model the environment and show how they interact together. For cost effectiveness, we follow this We use the incremental cost effectiveness ratio, which is the common measure used in cost effectiveness, where we compare two strategies, and the lower this ratio or ICER is, the more cost effective. And we use US dollars, disability adjusted life years, which is a common quality of life measure, and follow just convention for this calculation. Now, to give some idea of what these programs cost, we estimate from literature about 75 cents per school child and about $1.75 for community treatment per person. Now, we then do simulations using the transmission model to look at how school-based compares to community-based treatment. And here we have the simulation for school-based treatment. So you'll see prevalence on the y-axis and time over 15 years on the x-axis. And you'll notice that the different age groups are in the different colors. And blue represents the school-age children that are being treated, where prevalence goes down, and then there's subsequent reinfection over years, creating this up and down motion. But what you notice is that school-based treatment alone can't really drive down prevalence, although when you look at infection intensity, that more drastically reduces. And it isn't until community-wide treatment that you really start to drive down prevalence. So this is illustrating the importance from a transmission standpoint of expanding from school-based to community-based mass drug administration under some circumstances. We then look at cost effectiveness and find that indeed this strategy is quite cost effective. So we estimate about $160 to save 1 year of life. So once again, the lower this number is, the more cost effective. And typically we say if this number is below $1,000 to $1,500 US dollars, it's defined as highly cost effective. We then want to know when to treat. So looking at some of the questions about these prevalence thresholds that I mentioned earlier and reevaluating them under this framework. First, we wanted to know, can treatment be applied cost effectively at lower prevalence thresholds? So rather than waiting until 50% prevalence in children before treating once a year, what is the optimal threshold for treatment? And also, what are the implications on the global drug supply? So we wanted to create an epidemiological specific framework to ask questions for any setting: who do we treat, how often do we treat, and what medicines do we give? Now, this is the output of the model, so behind this is the transmission model, the cost effectiveness, but this framework allows us to answer these three questions. And the way it works is you look for the prevalence of soil-transmitted helminths on the x-axis and the prevalence of schistosomiasis on the y-axis. So you find those two spots, and then where they intersect, you can just move your hands there, and the color where they intersect, the color tells you who to treat and how often, as you can see on the legend. And the label tells you what medicines to give. So these would be the optimal strategies under a cost-effectiveness framework. We then looked at how this compares to current guidelines and found that compared to current guidelines for soil-transmitted helminths, school-based treatment is currently recommended at 20% prevalence, and we found that indeed that's the cost-effectiveness threshold. However, for schistosomiasis, the story was much different. Rather than waiting until 50% prevalence to treat once a year in children, we found that it's cost-effective at 5% prevalence, so suggesting that current treatment guidelines are too restrictive for treatment of schistosomiasis. We also wanted to define prevalence thresholds for community-wide treatment, so about 60% for soil-transmitted helminths and 15 to 20% for schistosomiasis. We then used the geospatial prevalence model, so taking all the data available and using environmental and individual household level predictors to get some type of understanding of the epidemiology of these diseases. We then used this prevalence model to estimate global treatment needs under current guidelines as well as the cost effectiveness guidelines. So the top two maps here are under current guidelines, and the bottom two maps are using this cost effectiveness framework. And in purple, we see praziquantel for schisto, and pink for albendazole for the soil-transmitted helminths. Now you'll notice that the bottom maps are more dark, indicating a higher need for treatment. And in fact, we see under a cost-effectiveness model, substantial populations would receive treatment that wouldn't under current guidelines. So a multifold increase for both medicines. Now, as with all models, it's important to understand our limitations and uncertainty. So the idea that countries and settings are different, the idea that there's uncertainty in the biology of transmission, and the common modeling assumptions we use, such as individual subpopulations are assumed to mix together, all the common assumptions we do. And the way that we approach this is by taking all of this uncertainty and mapping it all together into multiple simulations where we look at every possible combination of cost, of epidemiology, et cetera, and generate intervals to kind of show where the range of truth may lie. And we find that for school-based treatment, the estimate is more precise, while for community-based treatment, there's a larger interval of uncertainty. Now, we've also looked at vector control, especially snail control for schistosomiasis, and this is in collaboration with Charlie King at Case Western. And we find that snail control, which isn't part of the current recommendation, is indeed cost-effective about once a year in low-burden settings and more frequently in high-burden settings where this additional intervention is needed to really break transmission and bring transmission down. The policy implication has been a lot of conversations with NGOs and the WHO. Last year, the WHO revised their strategy to focus on adults for schistosomiasis, which was nice to kind of see research translating into policy. But this is still not quite the full revision of the global strategy that we're hoping to work with between the academic community and policymakers. We also recently co-authored an article including many people across NGOs, USAID, WHO, to call for a strengthening of the global strategy, incorporating a lot of the results I talked about today, but also results from many other groups, both in the NGO sector as well as in the academic sectors. So the take-home points is that community-wide mass drug administration can be highly cost-effective, that integration and thinking about multiple worms together is important to optimize cost efficiency. Thresholds are lower than what's currently recommended, so current recommendations may be too restrictive, and snail control has a role in control and elimination. And this all comes down to looking and re-examining our global strategy. So thank you very much. I'd like to acknowledge funding from CIGH, as well as many other sources, and the support of mentors that are life-changing. So thank you very much.
Thanks a lot, Nathan, for a clear presentation on a really important problem, but one that's not always on the forefront of people's thinking. One question I have, as I think about soil-transmitted helminths and the approach of mass drug administration, is drug resistance. I mean, we know that these helminths, that very closely related organisms in agriculture, we can no longer use the class of drugs that we're using for mass drug administration of people. And have you thought at all about your model and how that might change if we consider the likely emergence of drug resistance?
So this is a very good question, and probably a question that's crossed a lot of your minds. It's very counterintuitive when we think about stewardship for medicines. What's important to note is that for these helminths, drug resistance, while it hasn't really been rigorously documented in human populations, has been very well documented and has been a big problem in livestock. And so the broad answer is that when we look at this literature on animals and drug resistance in animals, we can estimate a threshold above which drug resistance, the probability of emergence, increases substantially. What that is about 80% coverage with treatment once or twice a year. So in terms of how we interpret the modeling results within that constraint is that we don't ever really test strategies or report strategies that are above that threshold, where essentially above that may breed drug resistance. So we always try to keep our recommendations within the best of our knowledge from the veterinary literature. The other aspect is when looking at veterinary literature, that provides a more conservative estimate when we think about animals mixing together, that if a resistant parasite did emerge, it would be much more likely in a very closed, confined environment that resistant parasite would then spread. So that's the main way we've done it, but it's very much a very important thing, and there's always a paragraph we write in our discussion where, as we think about increasing treatment, you're increasing treatment pressure, and so because of that, equal money or significant attention should be given to monitoring, or at least rigorous monitoring at sentinel sites. Good question.
But I'll just talk loud.
Yes.
Really nice, clear modeling presentation. I was curious about what some of the environmental drivers of helminthes were in the maps of Africa that you showed in that model.
Yes. So the map that we showed was done by led by a group at the Swiss Tropical Public Health Institute, and basically what they did is they took a systematic review of literature and also basically wherever we could find prevalence data that had some geospatial component so we know where it was taken from. In terms of the environmental predictors, a lot of it was about soil suitability and temperature, things that have been used in the past and validated as effective predictors. But these maps are not at the point where we can say, we can point to one spot and say like, you know, at this high resolution, this is where we should go treat. Rather, it's helpful to kind of understand broad stroke patterns, and especially in this instance when we would want to look at the difference and treatment implications under different guidelines. In terms of the specific environmental predictors, a lot of it is around rainfall, soil temperature, acidity, and I'd be happy to share those papers with you as well.
Thanks.
Hi, I was curious about your transmission models. You mentioned something about interaction of people with the environment. Can you give us some more details about what those models look like? What are the things that you consider in that?
In terms of the environmental component?
Mm-hmm.
So it's important to note that especially the differences between the two worms. So for the soil transmitted helminths, there's certainly that cycle that happens outside of the human, mostly in the soil. For schistosoma, the cycle outside of the human is much more elaborate. So it includes many different forms, it includes a snail intermediate host, and many other factors. Because the biology is so poorly understood, most of it is just modeled as a separate compartment that basically the relationship is calibrated. So you kind of look at how, based on the infection in these different age groups, how that would then create this environmental reservoir that would then drive reinfection. So it's essentially modeled as a compartment similar to the different age groups. There have been other groups, especially for schistosomiasis, which has this more elaborate life cycle, they've tried to more explicitly model this environmental reservoir, but you can start to think of some of the data limitations, especially in the general field of tropical diseases where the biology isn't always fully understood. So the benefit of modeling to that detail without the data is just, you know, typically seen as not worth it.
I was wondering, you mentioned that snail removal was also a cost-effective solution. How would you go about doing snail removal when they're all up and down the rivers in these countries?
Yeah, so we should bring you up here. So a couple approaches. So in the past, it's been mostly chemical molluscicides. And this is basically looking for bodies of water anywhere from typically ponds or lakes or the typical water supplies we'd expect, and spraying chemical molluscicides. Other groups at Stanford have looked at biological means of control, so such as using prawns and which eat the snail. But historically speaking, and China's probably been one of the countries that's really focused the most on vector control through snail control, has been through chemical means. And it's just you have these different types of sprayers. But you're right, I mean, it is challenging, and the reproduction of these snails is pretty impressive. So it's not a one-time solution, rather it's a repeated thing that you have to do. And you kind of can time it around the rainy season when these snails will reproduce more. Great, thank you very much.